Our next speaker is Dr. Patrick O'Gara from Boston. He's the Watkins Family Distinguished Chair in Cardiology and Professor of Medicine at Harvard Medical School and based at Brigham and Women's Hospital. And he's going to speak to us about the ACC, American Heart, and ESC valve guidelines.
Thanks very much, Dr. Lowry. Can you hear me okay? We'll try the lavalier mic so I can walk around. I'm too short to stand behind the lectern. I want to thank Dr. Zoghbi and the other course co-directors for including me in this fantastic symposium. These images are absolutely spectacular, are they not? It's really quite a learning experience. I'd also like to say that I do have a few disclosures relative to this talk, but chief among them is not listed here on the slide. I am a consumer of what you do. As Dr. Martin knows, I'm not very good at reading echocardiograms, but I am the person who understands from you your narrative descriptions of various phenomena, whether it's moderate or moderately severe, or it's mildly moderately severe, or some combination of that. So I appreciate the emphasis on semi-quantitation, and I think I'm too old to understand the techniques related to PISA and volume flow. I did spend 35 minutes on the phone yesterday from an airport lounge trying to gain pre-approval for a cardiac MR study in a patient with mitral regurgitation, the severity of which was not clear by echocardiography. So we do have a few more hurdles to cross before we can actually achieve precision diagnosis in this era of precision medicine. So Bill asked me to speak about the guidelines that have been recently published and updated by both the American Heart Association, American College of Cardiology, as well as the European Society of Cardiology. And we're just going to set the stage by reminding you that valvular heart disease occurs generally over a very long time frame, especially chronic valvular heart disease. There are exceptions to this paradigm, such as patients without valvular heart disease who develop acute infective endocarditis and become very sick in a short period of time. We're going to focus the remarks here on the right-hand side of this particular slide in patients who have severe disease, whether it's symptomatic or asymptomatic, and among the asymptomatic patients, those who have preserved or those who do not have preserved ventricular function. Bill has already touched on the very important and one of the first responsibilities of those of us as clinicians to distinguish primary from secondary mitral regurgitation. These etiologies are very different, and they come with an understanding of differences in the application of interventions. We don't really approach secondary mitral regurgitation with the same mindset that we approach primary mitral regurgitation. And the distinction here is really boiled down to the issue that secondary mitral regurgitation is a disease of the ventricle, and therefore its prognosis is more intimately associated with ventricular function than it is with the degree of mitral regurgitation itself. And I will emphasize from the start that no intervention, whether surgical or transcatheter, has been shown to improve survival in patients with secondary mitral regurgitation. Intervention for secondary mitral regurgitation is predicated predominantly on relief of symptoms in patients who are very sick. Sometimes, of course, that does not necessarily apply. Patients can have very limited infarctions, as Bill has shown us on one of his slides, and can be revascularized, and their mitral regurgitation could improve without the need for valvular intervention per se. So here's a typical case that walks into the office from Maine, where they don't like doctors and typically do not show up for follow-up. And this is a young man who fell off a roof, went to an emergency room, and somebody found that he had a heart murmur. And it looks to me as if he has mitral valve prolapse. And I would congratulate myself for recognizing that he has what looks to be a very large posterior leaflet, the belly of which prolapses posteriorly into the left atrium. And some of his chambers appear to be enlarged, and he's got this schmutzy signal. And of course, the narrative from this is that he has moderate mitral regurgitation. Should I be suspicious? And of course I should, on the basis of what Dipan just showed with respect to trying to nail down why it is that chamber enlargement might occur in the context of difficult to quantitate mitral regurgitation. Oh, and by the way, he also has moderate enlargement of his aortic root and is a funny-looking kid with a pointed nose and a high arch palate and lacy fingers. But did not have any genetic mutations that I could establish. So let's go over the indications for intervention in mitral valve disease. And Dr. Lowry will certainly touch on these in his surgical discussions. There's really no controversy that the onset of symptoms in patients with primary, typically myxomatous mitral valve regurgitation, should be referred for surgical intervention. And both of the guidelines actually stipulate that it would be desirable to do so well before the ejection fraction falls below 30%. That would seem to make sense. Obviously, one wishes to catch this sooner rather than later. But there's increasing pressure on us to understand the natural history of asymptomatic primary mitral regurgitation. And I think there is increasing pressure on general cardiologists to refer patients earlier and earlier in the natural history of this disease in the absence of randomized controlled trials that establish clearly that earlier surgical intervention beats a strategy of conservative management and referral once an indication emerges across the natural history of the disease. So what do patients with primary mitral regurgitation experience? They experience onset of symptoms or some other indication for referral for surgery on average about 5 to 7% per year. And this natural history is just a touch steeper, interestingly enough, than the natural history of patients with asymptomatic severe aortic stenosis, a touch steeper. And that means, of course, that we as clinical cardiologists and in combination and collaboration with you as imagers need to be on top of this so as not to allow ventricular function to deteriorate. So these are the indications in patients who are asymptomatic, and you can see there's concordance with respect to a reduction in ejection fraction below 60%. And then our guidelines differ with respect to the measurement of the end systolic dimension, above which one would consider earlier referral for surgery. In the United States, that measurement is 4 centimeters, and in Europe, it's 4.5 centimeters in asymptomatic individuals with preserved ejection fraction. And I think this particular difference is not very important and not very significant. And I also think, as a consumer of echocardiography, sometimes it's really hard for me to know the difference between 3.9 and 4.1. I should probably know the difference between 4 and 4.5. But this, I think, difference relates to a difference in the interpretation of observational data sets, which sort of get into this Talmudic discussion about what's more important than something else. So let's talk about reasonable indications to refer somebody to Dr. Lowry, and that would be recent onset atrial fibrillation or the development of pulmonary hypertension, which typically signifies that the MR has been severe for a long enough period of time that there have been vascular changes in the lung bed. And then in our guidelines, we just within the past year have offered this reasonable indication for us to consider earlier referral for surgery, and that is watching somebody over several years as their ejection fraction begins to fall towards 60% or their end systolic dimension begins to increase towards 4 centimeters. And it is reasonable to do so, I think, on the basis of what Dr. Lowry and his colleagues have been able to accomplish with surgical intervention in appropriately selected individuals. Outcomes are terrific. Therefore, the threshold has been reduced. And I also think that this is offered to us by virtue of the fact that it's very difficult to know the difference between an ejection fraction of 59% and one of 63%, I think, depending upon who does the study, right? What kind of blood pressure the patient had, whether they ate breakfast or something in between. So there's enough wiggle room here to offer an opportunity to exercise judgment, which is, I think, part of the reason for which we struggle so much with guidelines. We should never strap ourselves into a chair by which we cannot escape. And then, of course, the most controversial of the indications for which it might be reasonable for me to send a patient to Dr. Lowry would be in somebody with normal ventricular size, normal ventricular function, who has no pulmonary hypertension, has not had atrial fibrillation, and is rock solid stable, and is increasingly anxious about his or her long-term outcome with respect to the development of atrial fibrillation or heart failure. And how good is your surgeon, I think, is the last particular parameter that you need to incorporate with respect to decision-making to send an asymptomatic individual with a good LV to surgery. You will not make them feel better, and they have an obligatory risk of stroke in some series that approaches 1%. And there's nothing worse, of course, than sending your first 42-year-old with asymptomatic mitral regurgitation for surgery and have an air embolus or some other unforeseen complication. And then, of course, don't forget that atrial fibrillation will occur 35% of the time after surgery, whether they've had it preoperatively. Then you're off to the races, a little bit of anticoagulation, readmission with pleural effusion, a little fever, pericarditis, and it's not necessarily a great experience. That's sort of, they think, the basis of taking care of these patients. Even the Europeans feel comfortable in referring patients under this particular indication, but they do so with a couple of caveats. They're especially happy to do so if there's a flail leaflet, which implies more severe regurgitation, natural history of which may be a little worse than patients without flail. And then, of course, left atrial enlargement, to which Bill referred, which is a systolic volume index that exceeds 60. The Europeans also put in a reasonable indication in very sick patients with bad ventricles in whom there's a high likelihood of a successful repair. And again, a recommendation like this is a reflection of how good our surgical colleagues have become in managing sick patients with this kind of pathology. Now, I show this for Dr. Lowry because we were both talking about Dr. Adams, and I don't know if this is really the benchmark against which we can measure the quality performance of other surgical programs in the United States, but Dr. Adams has published this information a few years ago now, Randy, I think maybe as many as 4 or 5 years ago, showing that in his hands, nearly 100% of patients referred to his institution for mitral valve intervention in the setting of primary disease actually underwent a successful repair with low operative mortality and low perioperative stroke rates. These are very, very high benchmarks and not typically achievable by the average institution in the United States. So lastly, there are some reasonable some indications for which you might consider referral for surgery, and that would be patients with a bad ventricle. How about patients who have rheumatic heart disease, excuse me, in which there's a combination typically of MR plus a little degree of MS, and in an elderly population or an older population, how likely it is that a repair can be accomplished, especially if you're reluctant to put in a prosthesis, especially if there's an issue with respect to long-term anticoagulation. And then, of course, for the transcatheter techniques, which I will defer to my colleague who will be speaking later in this session, both the Europeans and the US authors of the guidelines have placed this in a very conservative level of recommendation, that the clip in the United States in particular is relegated to the care of patients with primary pathology who are very symptomatic and poor candidates for surgery. So it's a very conservative recommendation. We'll see what happens as transcatheter techniques begin to continue to explode. And here's an example of somebody with ischemic mitral regurgitation as a prelude to our getting into how it is that clinicians should look at patients with chronic secondary mitral regurgitation. Now, Bill has already pointed this out, and that is, I'll just take your eye here to the middle of the slide, and the definition of chronic severe secondary mitral regurgitation is now consonant with that that the American Society of Echocardiography has published. In prior iterations of our guideline, we adopted the same definition of chronic severe mitral regurgitation that the Europeans did. I'll draw your attention here to the last column of this particular table. And this reflects the fact that in patients with chronic severe secondary mitral regurgitation, lesser degrees of regurgitation may be associated with a worse prognosis. But that's not to say that lesser degrees of mitral regurgitation are actually severe. Severe mitral regurgitation is severe mitral regurgitation, as far as I can understand. And it's incumbent on us to use these semi-quantitative techniques, and it's incumbent on you to inform me when these things kind of fall apart and there's uncertainty and the need for additional testing in order to clarify a situation. We don't operate on patients with moderate mitral regurgitation in this context. So the indications for intervention in secondary mitral regurgitation are generally more conservative for the reasons I've stated. Patients with bad ventricles, and intervention has not been shown to prolong survival. Severe mitral regurgitation undergoing other cardiac surgery is a no-brainer. Severe mitral regurgitation with a very bad ventricle, when revascularization options exist and there is evidence for viability on preoperative cardiac MR testing or PET testing, is something that could be considered, I believe. And here in the United States, there has been a gradual migration from repair to cord-sparing replacement for patients with chronic secondary MR. And I just want to emphasize this point again. In patients with primary MR, repair beats replacement. In patients with secondary MR, this is a new recommendation, and this is derived almost directly from the results of the Cardiothoracic Surgery Network ischemic MR trial, in which we showed among patients with severe ischemic MR, I'm just drawing your attention to the green bars here, that the prevalence of moderate to severe recurrent mitral regurgitation at 2 years exceeds 50% in a population of patients with chronic severe ischemic mitral regurgitation referred for surgery at academic surgical centers across the United States and Canada. With cord-sparing mitral valve replacement, the prevalence of recurrent moderate to severe mitral regurgitation at 2 years is less than 5%. And the presence of recurrent moderate to severe mitral regurgitation is not good, as it leads to an increased risk of rehospitalization for heart failure over time. So these are some of the even more conservative recommendations for you to consider in sending patients for intervention in the context of secondary mitral regurgitation. I'll draw your attention to the second row, right-hand column, the use of the mitral clip for patients with secondary MR, and I think our transcatheter interventional colleagues will talk further about this, but it is now something that can be considered in Europe, and of course here in the United States we're waiting for the results of additional randomized trials before making a recommendation. For moderate ischemic MR at time of CABG, the guidelines in Europe are completely silent, and here in the United States have come clean and said we have no idea whether it's beneficial to do a downsized annuloplasty repair in patients with moderate ischemic MR who require CABG. This is randomized data, which I show you here again from the CT network, have not shown any benefit with respect to downsized annuloplasty repair regarding an endpoint of reverse remodeling, no benefit with respect to survival on the left-hand side of this particular slide, and no benefit with respect to an aggregate incidence of major adverse cardiac and cerebrovascular events. We haven't been able to show in a randomized fashion that it is effective. It may be safe, maybe not. Look at this. Higher rates of neurologic events and supraventricular tachycardia perioperatively in patients undergoing downsized annuloplasty repair compared against those who underwent CABG alone. So I'm not sure the Europeans don't have this right. We should be silent as to whether or not this from a clinical point of view, should be tackled at the time of mitral valve intervention. And I'll leave you with this, which Bill referred to, our expert consensus recommendation that was published last year in JACC, a very busy slide, but on the far left-hand side, I just want to point out those things that we are actually obligated to do as a team of general cardiologists, primary care practitioners, imagers, invasive imagers, interventionalists, cardiac surgeons, and then, of course, what happens on the back end. It is appropriate for us to make sure that we identify patients with mitral regurgitation. The single greatest obstacle to getting patients to the goal line on time is the lack of appropriate identification. People don't listen to chests in emergency rooms, let alone primary care physician's office, right? We're way too busy. It's much easier to assess a troponin, a D-dimer, a BNP, and do a chest CT than it is to listen to the heart. Or when you see somebody listening to the heart, the usual diagnosis is RRR, right? Regular rate and rhythm, right? Okay. And then for us to define it, according to what Bill has laid out in his beautiful guidelines between primary, secondary, and sometimes patients with mixed, assess, quantify, 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 imaging expert, imaging expert, imaging expert, and then obviously collaborating with interventionalist surgeons and general cardiologists and providing follow-up so we can be honest about our outcomes. Atrial fibrillation does happen late after surgery, and we need to be attuned to that. Thank you very much for your attention.